Good morning, everyone. I'm Neil Kelman. I'm the president of the Institute for Family Health and the chair of Family Medicine and Community Health at Mount Sinai. This morning's extra special because this morning we get to show off some of the incredible talent and commitment of our own faculty and staff in talking about addiction medicine. And I will introduce our moderator and leader, Dr. Joe Lurio, who is a family physician. He's practiced in underserved communities for over 40 years, a longtime colleague and friend. He's board certified in addiction medicine, has a lifelong interest in treating addiction and caring for patients with substance use disorders. Many of you know that he served as medical director of our Amsterdam Family Health Center for many years and is currently program director for the Institute's ACGME accredited addiction medicine fellowship. Dr. Lurio himself provides medication-assisted treatment for opioid dependence and other addiction services as part of his family practice, and regularly provides presentations and training on MAT within the Institute and in the broader community. Dr. Lurio's interest in addiction began when he was performing anthropology fieldwork in New York's Bowery as an undergraduate student at Columbia. Later, as a physician in the Indian Health Service, he broadened his experience in treating alcohol, inhalant, and opioid use disorders. When he came back to New York, he published research in screening pregnant women for substance use and participated in early trials of primary care office-based methadone maintenance. He's the Institute's champion and expert on integrating substance use identification and treatment into primary care. I don't think there's anything that we could be doing that has the potential and probably the history of saving as many lives as we have through this work and will continue to do. We have a cast of thousands, star-studded cast this morning of all folks that are with the Institute, and Dr. Lurio will be introducing them as we go along. So sit back and be prepared for a great presentation. Joe, I'll turn it over to you.
Okay, thanks a lot for that, Neil. Let me see if I can get my, let's see, I hope people will be able to see my screen here. Okay, that looks pretty good.
You're good.
Okay, great. All right, so before I get started, I just actually wanted to say something which is not really related to this presentation, but you know, I think it was last week I saw in the New York Times an article that was saying that the number of abortions in Texas was not as low as was expected after they passed their draconian law. And some of that was because a lot of women were traveling out of state, but a very large percentage of that was because a lot of women were getting medical abortions they were receiving from medications that were being mailed from outside physicians. And when I saw that, I thought, gee, really, thinking about Dr. Prine and Dr. Lesniewski and the whole, the whole group of people that we're associated with, those brave and brilliant physicians that have really made a tremendous difference, and certainly following the mission that we all have. And I just felt so proud to be associated with these tremendous doctors. So this has nothing to do with this presentation. I just had to get that off my chest. All right, I apologize for that. Best laid plans. All right, so let's get to the actual presentation here. All right, so addressing overdose mortality in family practice. So besides the New York Times article I was mentioning about abortions in Texas, this appeared last fall after there was some careful analysis of data from the first year of the COVID pandemic. And as you can see, the number of deaths from drug overdoses exceeded 100,000 a year. This is more than the toll of car accidents and guns combined. This is also the first time that drug overdoses surpassed the number of deaths caused by alcohol in the United States. So this is quite a a grisly statistic, and is talking about the collateral damage of the epidemic of COVID. Now, I'd like to drill down a little bit on what this means to us in primary care, and I'm going to be using as examples the data that we have from the Institute for Family Health. I'm aware that there are people in this webinar who are not IFH physicians, but this allows us to drill down a little bit more and see what this all means. All right. So if we're looking at the clinics that are from the Institute for Family Health in New York City, you can see that those neighborhoods are worse than the New York City as a whole as far as opioid deaths. First is East Harlem, where we have our largest clinic, and which is the site of our Harlem Family Medicine Residency Program. And there, as of 2015, this is before the pandemic, where New York City as a whole had 9.4 deaths per 100,000. In that particular neighborhood, it was double. It was 18. And in Soundview, which is where we have the Stevenson Clinic, not as severe, but certainly much more than New York City as a whole. Morris Parks and Bronxdale, where we have Walton and Mount Hope, similarly elevated, and even in downtown New York, where we have our 17th Street Clinic and our Beth Israel Mount Sinai residency program, it's still significantly higher than the New York City average. All right, so that's sort of the neighborhoods and the group populations that we take care of at our FQHC. So the question is, what happened in New York City with the COVID pandemic? How did that affect mortality? All right. So what happened was overdose deaths increased to 30 per 100,000. Now, opioid deaths were increasing from 2015 to 2019. Right? Remember, they were a little under 10 per 100,000. They went up to about 22 per 100,000 for the year of 2019. But we had a full 50% increase in 1 year just with COVID as people locked down. All right. Now, if we're looking at healthcare disparities, which we want to do, you'll see that Black New Yorkers had the highest rate of overdose death, 38.2 per 100,000, and the largest absolute increase in death from 2019 to 2020. Okay, and getting to the Bronx, we see that the death rate from overdoses was 68.7, almost 69 per 100,000, which is just horrendous. And remember, we're looking at a little under 10 per 100,000 in 2015, which at the time was considered to be very alarming and was causing major changes in practice nationally. All right. So we just don't practice in New York City, and it's useful to take a look at our practice upstate. So in Ulster County, now where New York City is, I guess, I don't know, what is it, 8.9 million people, something like that. Ulster County is a lovely county in the foothills of the Catskills, population about 181,000 as of the last census. And you can see, now this is for last year, as of the middle of September, we were able to get real numbers from the health department, real time, and we can see that actual, numbers of people who had died from overdoses: 15 in the city of Kingston, 6 in Saugerties, 15 in the New Paltz area, 6 in the Ellenville area, these are people who died. I mean, it's the one thing about being a family practice in a small community, especially rural or semi-rural communities, is you really get to know everybody. And so you're looking at statistics, per 100,000. That's one thing, but to see individuals who have died. So if we take a look at these real numbers, real people who have died, in this upstate county, we're looking at a projected mortality calculated at 59.3 per 100,000. So that's really very close to the worst area of New York City, the South Bronx. Okay. So, I'm looking at Dr. Kalman, and we've got a busy primary care practice. We're trying to take care of people's blood pressure and diabetes, and meet quality metrics. And my God, I mean, this is terrible stuff. But what can we do just for primary care doctors in our FQHC? Well, it turns out that there is something very significant that we can do within our primary care practices. Medication for addiction treatment, especially or very specifically for opioid use disorders, will reduce expected mortalities to less than a third, all right, of that expected. So we're talking about a 70% reduction in overdose mortality. And when we're looking at the data for all-cause mortality, all right, it turns out that somewhere between 20 and 50% reduction in all-cause mortality, not just overdose deaths, but when people who are on medication for opiate use disorder, methadone or buprenorphine Suboxone, the death rate, annual death rate, goes down somewhere between 20 and 50%. All right. So there's our reference from the BMJ. They did a very, very careful meta-analysis looking at many prospective trials and other publications internationally. This is a worthwhile reference to take a look if you want to look at this. So that's the overall data. Now, getting to another way of looking at it, number needed to treat, what does this mean? Well, in the context of what else we do in primary care, in doing screening for breast cancer, doing mammograms, we're talking about a number needed to screen of about 84. Now, this is data coming from the radiologists. I know there's going to be people in this audience who are going to, argue that this is not a realistic number, but you could certainly say this is a best case number. Where the people who are clearly biased towards mammograms were trying to make their best case, and they came up with it would take 84 women between the age of 50 and I believe 75 screening annually for 10 years to save one quality adjusted life year. All right, so looking at something not just quite as long-term prevention, we're looking at hypertension, treating of hypertension. The number needed to treat, and this is also in a high-risk group, elderly. It takes 29 hypertensive elderly to be treated for hypertension for 1 year to prevent one stroke. So, I mean, I think that's around 29, 30. That seems to be a good ballpark of a good effectiveness number for number needed to treat. So what's the number needed to treat for buprenorphine? All right. Well, the data is this. For low dose, it's 1 in 4 to have a response. For intermediate, it's 1 in 3. I don't know who's calling me, but I just silenced that. All right. And for higher dose, greater than 16 milligrams, it's 1 in 2. All right. It's also very interesting to see that there's a very close dose response here, which is also talking about the validity of this as a medical treatment. So we're talking right here that the number needed to treat for buprenorphine is 2. Compare that to our usual practices of screening for breast cancer and treating hypertension. Our NNT is 2. Okay. Here's our reference for that. For those who want to take a deep dive into the evidence around this, this is pretty strong. Now, when we're talking about medications for opioid use disorder, we've got methadone, we've got buprenorphine. Both will provide a dramatic reduction in all-cause mortality. This is data going back to the 1960s when methadone was first introduced for opiate use disorder. And when we're looking at comparing these two, it turns out that buprenorphine, Suboxone, is a little bit more effective in the short run. Methadone is a little bit better in retaining patients. This may not be a drug effect. This may be related to the fact that we can only prescribe methadone in the United States in methadone clinics and outpatient treatment centers. And that may be beneficial as far as psychosocial interventions. And however, a lot of patients really hate that. They call methadone liquid handcuffs. It means that they are really tied to the methadone program. That's gotten a little easier with the pandemic. They've loosened up some of the rules about taking home extended doses of methadone, but that's pretty much the issue. All right, so in primary care, and we can't really prescribe methadone in our practices in primary care. So in primary care, the treatment of choice is buprenorphine, Suboxone. So Suboxone is a mixed partial agonist-antagonist. It has a long half-life. That's really key in opioid use disorder maintenance treatment. You don't want to have rapid ups and downs. You don't want people swinging from being intoxicated and high to being in mild or moderate or severe withdrawal and drug seeking. You keep people on a steady level of the medication, and that really is effective. So it's got a long half-life. It can be prescribed by any doctor, nurse practitioner, or PA. The overdose risk is very low because the higher you go in buprenorphine dose, the antagonist blocking effects start to be predominant. So there's a ceiling effect. It also turns out to be an effective analgesic when it's given BID or TID. Methadone, which also has strong efficacy, can only be prescribed for opioid use disorder in an outpatient treatment facility licensed for that, a methadone program. It also has a long half-life. It's highly regulated, which is an issue, means we can't really prescribe it. We can only refer people to it. It requires daily travel to the clinic. So I would say it's definitely a second-line treatment. A distant third is naltrexone, Vivitrol brand. It's pure opioid antagonist. It's very hard to get people on naltrexone who have opioid use disorder. It is given to people who have been incarcerated and therefore involuntarily made opioid free. And for people who are very strongly committed to being opioid free, this is a good alternative because it protects people from overdose if they do have a relapse or a slip. But it's hard to start. It's very expensive, and is definitely a third line drug. So I think there's general consensus in the medical community that we need to be prescribing buprenorphine in primary care, and we need to break down the barriers to doing it. We want to have what's now called low threshold buprenorphine initiation. We don't want to do what when we first started, saying people needed to be seeing a social worker, needed to be in therapy. If they were using any other illicit substances, they couldn't be on buprenorphine. We're the exact opposite. Someone asks for Suboxone, we should give it to them. We want it, it's a life-saving drug. I don't want to not give somebody Suboxone, just like if somebody is wheezing, I don't want to withhold albuterol. It's cruel and unusual punishment and clearly malpractice according to national standards. Okay, so talking about reducing barriers, we used to have a regulation that for doctors to prescribe buprenorphine, they had to take a day-long course. And that that regulation, has been rescinded. Now you no longer need to attend a special course to get the license. All you have to do is inform the federal agency, SAMHSA, of your intent to prescribe, and then your DEA number will get a X waiver attached to it. If you are going to be prescribing more than 30, you still have to take a course and get certified that way. But for the general primary care physician, nurse practitioner, PA, there should be no barrier for that. And here is the link that will take you directly to the page in SAMHSA, which allows you to file a notice of intent to prescribe buprenorphine. All right, so how are we doing nationally as far as this is concerned? I think it's good to take a look at national data. All right, turns out that only 7.5% of PCPs in the United States have a bup license and are actively prescribing. Actively prescribing means have at least one prescription that's been logged for buprenorphine. And as you might expect, half of all treatment is provided by a minority, only about 5% of active prescribers. So for PCPs, it would be 5% of that 7.5. So it's a very small number of doctors in the United States who are actually prescribing bup. And if we drill down into that 5% of active prescribers, really the vast majority are PCPs, internists and family doctors, mostly family doctors actually. And that's followed by psychiatrists, pain specialists, less so, and only 4% of buprenorphine prescriptions are coming from addiction specialists. That's mostly because there are very few addiction specialists. Addiction medicine has been a specialty only for a couple of years. And while it's expanding, it's compared to really all other specialties, it's just a little blip. We really need to make a change as far as that's concerned. All right. Now, how are we doing at the Institute? We can take a look at our data for our organization. And I can tell you that in 2018, we had 39 providers, doctors. In 2018, I think we also had nurse practitioners who were able to start prescribing at that point. We had 39 providers. In 2021, we had increased that to 57 who were prescribing on a monthly basis or so. Now, since we made changes, and thank you, Dr. Gale, for assisting in this, since we made changes in our regulations at the Institute for credentialing of providers, saying that you needed to have a buprenorphine waiver on your DEA license, 106 providers had prescribed Suboxone for the prior month. Now that's pretty amazing. That's now finally a substantial majority. This is not including residents. This is people who that are attendings and providers. But that's pretty dramatic. Now, the vast majority of the prescriptions are from a much smaller group, but we've got 106 providers who are actually writing prescriptions for bup, which is pretty tremendous. All right. Now, drilling down also at the number of actual patients, this is not prescriptions written. These are, this is prescriptions, not patients. All right. If we take a look at the number of prescriptions that are produced, and this is since 2015. And remember, 2015, we were already in the middle of the opioid epidemic, and we were actively pushing buprenorphine. We were able to be prescribing about maybe 800 prescriptions and for the quarter, and that has steadily increased to the point that we have over 2,000, in the last quarter of 2021. So this is really a tremendous achievement that we've had, and looking at that in the context of the very paltry increase in prescribing for buprenorphine nationally, in the paltry number of providers who have been prescribing. That's just tremendous. If you drill down a little bit more, though, you'll see that almost all of this increase is from our upstate or mid-Hudson practices. And there's been very little increase, a slight increase, definitely, but nothing like as dramatic as what we've had in mid-Hudson. The other thing that's worth looking at is that, and correct me if I'm wrong here, Dr. Kalman, but I believe that 2/3 of our clinical activity is from our practices in New York City. But we're looking at 2/3 of our buprenorphine prescribing is coming from upstate. So this is kind of backwards. Now, looking at this from another perspective, which is not buprenorphine, but from prescribing and dispensing Narcan kits, because this is another life-saving intervention that we can do, and which we have invested at the Institute. You can see that there have been more Narcan kits prescribed and dispensed on site in our upstate practice than in downstate, even though in New York City we take care of considerably more patients. There are a lot more patient encounters. The other thing that I think is worth looking at here, if I can take a second, is that there's a lot of variability. All right. So our largest practice, I believe, is Kingston, and we have a lot of kits being dispensed and prescribed, and that makes sense. But in Hyde Park, which is a small practice, but it's not negligible, much less. Port Ewan, which is a one physician practice, which has a lot of patients who are on high doses of opioids for chronic pain. 0 kits were prescribed and dispensed during the month of January. If we take a look in our New York City practices, there's also a lot of variability. There's a lot of Narcan kits prescribed, none dispensed up in Harlem, though Harlem is our largest practice, and it's nothing near what we've been able to do up in Kingston. And we have another practice, which is pretty large, one of our other training sites, Walton, in the Bronx. And remember, the South Bronx is a hotbed of overdose deaths. We had 0 Narcan kits dispensed or prescribed by our Walton practice. So that's a little disturbing. Now, another way of looking at our data, this is for institute-wide. This is not broken down by region or site, but I think it's interesting to take a look at this. Now, if we have here, this line here, patients on overdose risk registry given a naloxone kit, we're talking about 1/5, 21 to 23% of patients on this registry have been documented as either being prescribed or dispensed, or recording that they had their own Narcan kit at home. All right. Now, you can ask, well, how does someone get on this particular registry? They could be documented as receiving methadone or buprenorphine. They can also have other use disorders. They can be an alcoholic or cocaine or other stimulant use disorder. And you might be able to argue, well, what is the risk of somebody having an opioid overdose if they're an alcoholic? We can talk about those risks, but there's one other line here I want you to take a look at, and that is this one, just above it. These are people who have had a documented overdose in the past. Only 1 in 3 of those people have a documented Narcan kit. These are people who have already experienced an overdose. Now, what the heck is that about? Why are we being so negligent to have those people not have a Narcan kit at home? So, on one hand, the Institute is way ahead of the curve nationally, as far as having physicians who are licensed to provide Suboxone, who are actively prescribing it, and addressing this scourge. All right. But on the other hand, we got a long way to go. There's a lot of variability. There's a lot of inconsistency, and we got to do better. All right. So given that, I'd like to introduce our panel. These are people who hopefully will have a robust discussion to see what we're, how we can address these problems. Abigail Herron is the Vice President of Behavioral Health and the Director of Psychiatry and Addiction Medicine at the Institute for Family Health. She's board certified in adult psychiatry, addiction psychiatry, and addiction medicine. She's a distinguished fellow of the American Society of Addiction Medicine. I'm only a fellow of the American Society. I don't know how she got to be so distinguished, but actually I do know. And she's the editor-in-chief of Essentials of Addiction Medicine, a book that I think all of us should be owners of. InSung Min, Dr. Min is the patient-centered medical home coordinator at the Institute, as well as faculty for the Mount Sinai Downtown Residency Program in Urban Family Medicine, and serves on the Institute's Addiction and Chronic Pain Quality Improvement Committee. Dr. Min enjoys the challenge of continuously learning from her practice and her patients, and her clinical interests include correctional health, homeless care, HIV medicine, women's and teen health. Joel Panthappattu, who I'm sure I have never been able to say his last name properly, I apologize, serves as faculty for the Institute's Mid-Hudson Family Medicine Residency Program, where he leads the addiction medicine track for the residents. Ann Winters recently completed the Institute's Addiction Medicine Fellowship and remains at the Institute as a clinical research fellow. She's board certified in internal medicine and just passed her boards in addiction medicine. So congratulations, Dr. Winters. Prior to coming to the Institute, Dr. Winters worked at the New York City Department of Health and Mental Hygiene, where she has an extensive experience working as a medical epidemiologist. Dr. Rachelle Grad is a third-year resident in the Mid-Hudson Residency in Family Medicine. Her clinical interests include community medicine, pediatrics, psychiatry, and women's health. As part of her primary care practice, she has managed a number of patients suffering from opioid use disorder with buprenorphine, and has become quite adept at taking care of those patients. And Dr. Andreas Lazaris is a second-year resident at the Mount Sinai Beth Israel Residency in Family Medicine, who is a member of the Institute's Addiction and Chronic Pain Committee. So I'm going to ask this group a two-part question to get the discussion off. The first is, what can we as an organization committed to the health of underserved individuals and the communities where they reside, what can we do to increase the utilization of therapies proven to reduce mortality from opioid overdose? And what can we do to address the reluctance of some of our medical and nursing professionals to treat people suffering from substance use disorders? All right, so I'm going to stop sharing my screen, hopefully, and let's change this to start the discussion. Anybody want to start? How about you, Dr. Herron?
Sure. So, obviously I have chosen to do this as my life's work and find that I love working with this population. I think lack of exposure is one of the biggest barriers. I personally never expected to be an addiction doctor. I did not go into medical school or even residency thinking that that was what I wanted to do. It wasn't anywhere on my radar. And I think it's easy to think of as very other. So I think exposure is the biggest thing. So, I challenge everybody to take that leap a little bit and maybe take over, a case from a colleague that has Suboxone, or kind of dive in a little bit more in a case that's maybe having a problem with, overusing benzos or things. Why I love this work is that I have found this to be a group of people that are capable of such transformation in their lives through behavior. And that's not something we get with schizophrenia or cancer or a lot of other illnesses, right? That you can really put all of the control back onto the patient. And to me, that's the really exciting part. So, I think exposure is the biggest thing here. And we're fortunate to be in a place where some people are doing this work, but it's still kind of siloed. So, that's, I guess, my quick pitch of how we might get more people interested in doing more of this.
People on the panel, you can unmute yourselves. I think we have the capability to be able to talk over each other, so to speak.
I think one thing that I try to tell everybody is replace the term substance use disorder with diabetes, hypertension, depression, anxiety. It's not an overnight process. It is much like any of those other conditions. It is a ongoing process, and it requires a development of a relationship with the patient. And understanding that it does take time, it really is a bit freeing in the sense that there's not this immediate expectation that you're going to make everything better. That's one thing. I agree with Dr. Herron tremendously. Exposure is really another thing that really, if you have the opportunity to take care of these patients, just seeing that complete transformation that people have, whether it's getting a job because they're able to be sober for a period of time, I think is so dramatic, and seeing their lives greatly improve. And then the other thing, when it comes to helping, I really have to give a lot of props to Upstate, two of our coordinators, Gina Altabrando and Julian Mercado. They are invaluable when it comes to helping set up follow-ups for lab visits, for setting up transportation, all of these things that are so vital and so kind of roadblocks that for some individuals can happen. They are so unbelievably vital, and they're such an integral part of the entire process for us.
Yeah, I mean, I think that's very important. A lot of times we're very focused on the physician or the healthcare provider as the what's driving the show. But I do think that one of the keys to the success in the Mid-Hudson practice is that there are two very, very capable patient navigators who are dedicated entirely to working with this population and promoting linkages between the Institute and the emergency room and peer counselors and even people leaving incarceration. So that's a really good important point, Joel. Dr. Winters.
Yeah, I would like to agree very much that I think that in order to increase the number of patients that we can engage in particular in medication for opioid use disorder, I really think lowering the threshold in many different ways is important. And so I think one of the things that the Upstate navigators do so well is they identify patients who have fallen out of care. So they've missed an appointment. And any healthcare system, our system, like all systems now, are so hard to navigate for patients. And so getting another appointment, making sure they don't run out of medications is so critical to keeping them engaged in care. And so I think that's a really important thing, is to have staff who are really dedicated to that work throughout our organization. And another way to lower the threshold is, I think, another thing that happens upstate with Joel's clinic is to have a standing clinic where we're regularly seeing patients with addiction use, and also where we can prescribe Suboxone as a bridge to people who have fallen out of care with their regular provider. So, once a week or twice a week, have a way to bring people in where we know we have a regular clinic happening and we can add somebody on for a quick visit. I think that would be a way to increase the number of patients who stay engaged in care. Those are just two things that I've been thinking a lot about in the last year when I see some of my patients fall out of care and I try to re-engage them, and it's it's a challenge. So I think that would be really important.
I think, thank you, Dr. Winters. One of the things that actually Dr. Min and I, both at the 17th Street program, have been talking a lot about is this also kind of addresses the question of exposure, especially from a resident education perspective, which is, right, do we have a dedicated clinic? Do we have a dedicated slot where we can see patients, and residents can say, I'm going to join Suboxone clinic today so that I can see, 5, 6, 7 patients back to back and understand kind of the variability in prescribing, the variability in how patients use the medication, dosing, titration, side effects, these kinds of things, instead of seeing, a one-off case when we can. And I think in the same way that we've organized, procedural clinics, and people can have kind of quick, dedicated weekly access to being able to get long-acting contraceptives, having the same access to an addiction medicine provider, kind of on a dedicated day, which can also increase the access that residents have to managing this type of care, kind of in a more consistent way, which I think would hugely alter, potentially, like Dr. Herron was saying, even the course of someone's residency experience, but also maybe what they go on to do afterward.
I'd just like to bounce off that. I know Dr. Winters said that we're concerned about people that are falling off of care, but I think we should identify those that need care as well. So to do that, I think we need to take away, I think there's still a stigma attached to this. And I've had many personal encounters with patients where they come in and they say they were afraid to talk to another physician because they felt like they were being discriminated against. So Dr. Lurio has been really good at mentioning motivational interviewing and getting the patient willing to open up about their care using the 5 principles. So that's been really good. Another thing, I was looking at a research study based out of NYU, and I think they were kind of looking at the social determinants of health, and they found that housing is directly related, or unstable housing is directly related to increased addiction and mental health disorders. So I think using a holistic approach of medicine and kind of getting a whole, instead of just focusing on the addiction and the drug abuse, trying to get everything sorted out for our patients would be great as well.
I really love this panel because I feel like there's a lot of experience, and I know that Dr. Grad is someone who has a large panel of Suboxone patients as a resident, so it'd be really awesome to hear a little bit more about that. What I was going to say is I am a family doctor first and foremost, and I see these people coming in, different patients with different issues, and I think we know that we need help as a provider. Like, we can't just do it alone. We need a team-based approach. And I think we've done it so successfully in a lot of other areas like diabetes, Compass, prenatal care. And these are huge success stories. I feel like, having been at the Institute for a while, like when things didn't have that versus when we did have it, care navigators, shout out to all those teams, which make a huge difference. And in some ways, like, I think perhaps like to identify the patients, then to link to care, then to engage, and then retain, perhaps a team-based approach would be helpful. Because I think Julie Schultz, she's a advisee of mine as a faculty, and she's an ECRIP fellow, and she did a study, and I feel like it was really enlightening to read her results. I think she identified things that seemed like barriers, and there's a variety of barriers that she identified, things that people have mentioned, like exposure to patients. I think the top barriers that people had kind of checked off in the options were like the training and the kind of wisdom of doing things. And then also, I think number 2 was the number of patients. Number 3 was maybe the need for a patient to see mental health, which I think kind of speaks to more of an older school attitude about like how to take care of patients. Like, maybe they need to kind of go to another, just get mental health before seeing us, which I think the Institute actually had done early on in our Suboxone program. And I think like 39% said that they didn't feel supported, which as a provider, I'm just imagining, what does that mean exactly? She didn't really break it down in her research, but it is a research potential for anyone out there, possibly. But I think like time, Q15 visits, especially engaging in something that you've never done before, I think it feels daunting. Teams help with that. When I'm an HIV provider, when I do that care, knowing that Compass has my back, or I have Compass's back, or like we're working together as a team, that really helps me. I feel the same way about my diabetic patients that are like not doing super well. So I think like there's a lot we can do, but I think we've already done a lot upstate, and it would be really awesome to just sort of like mirror some of the things that have led to success there.
We have a question in the chat. I'm wondering if I can read it out for the group.
Yeah, please, Autumn.
So thank you all. Even as the Institute has increased access to medication-assisted therapy, there are still challenges in easily recognizing patients, as it may seem like opening up a proverbial can of worms for which we may not be equipped to provide help. What are tools that we providers have that can help us identify patients more easily?
Well, let me start with we have various tools that are helpful. One of those tools is that in our reporting workbench, in our quality dashboard, you're able to see how many patients that you have that are on the risk list for having an opioid overdose. And if you can start right there and reach out to those patients simply by saying, listen, it looks like that you've never had a Narcan kit. You don't have to be talking to them about starting, Suboxone. You can just say, this is a useful thing to have. I say to my patients, it's like having a fire extinguisher in your kitchen. You don't plan on having a kitchen fire, but better to have it and not need it than need it and then realize that you have nothing to deal with the emergency. And that's a good way. That's non-judgmental. That's non-threatening to sort of open up the discussion. I don't know. Is there anybody else who has any thoughts about how we can, identify these particular patients?
Well, I want to spin that slightly to challenge us also to just look first for the patients who are walking in telling us exactly what they're looking for. We already don't meet the needs of everybody that comes in saying they're seeking this type of help. So, depending on the practice, depending on which provider you happen to get scheduled with, depending on how you might call and ask for an initial appointment, we are turning away people who have self-identified as having problems with opioid use disorder and wanting to access care. Those are the easiest people. I always say that the easiest part of my job was when I ran an addiction day program, because everybody there already acknowledged that they had an addiction. So I think a lot of people touch on, what Dr. Gale is speaking for the group on, that it's hard to initiate those conversations. It's hard to sort of figure out who on your caseload might be having a problem. And while I certainly encourage people to still do that work, I think our first step would be to really present ourselves as open to receiving those patients in a comprehensive primary care model. So I'm not suggesting that we're just doing standalone addiction or that we're not treating this as part of the rest of what we do, but I think that that's really opening the door. So making it known in our practices that we prescribe bupe, putting up the signs saying, ask me about naloxone, getting those care navigators out there. A lot of work's been done in Mid-Hudson to proactively reach out to patients who have chronic opioid prescriptions, who may not even have addiction, and to get kits into their hands. And so those types of things start to put that out there, and our patients talk to one another, and then they start to say, hey, you know what? Dr. P can help me with this. He already helped me with something else. And so I think that that's the first step, and it brings a lot of it out of the woodwork, and it also helps people to feel a lot more comfortable doing this work.
I will say Ulster County has really great support from the community as well. We have Ulster County's Healing Communities study team who partnered with the Ulster County Sheriff, and they created spike alerts, which give real-time updates to people that may need treatment. They have connection to the media. They do radio PSAs. There's public education. And then they also direct patients to places they can get Narcan and treatment and harm reduction supplies, including IFH. So I think our community does a really good job in trying to direct patients where they need to go to our clinic.
I also wanted to comment. So one of the thoughts in the chat was the kind of quote unquote proverbial can of worms. And and one of the questions I think that Dr. Lurio had presented at the beginning was, how can we as providers connect people with resources that could potentially save lives? And I think first off, understanding and acknowledging that substance use and substance use disorders have a variety. They come in many, many shapes and forms. People have varying relationships with substances, may or may not identify as having a substance use disorder, may not even qualify, but do have a relationship with the substance. And I think also in turn, recovery or treatment also means different things for a lot of different people, depending on their relationship with that substance. And a lot of the relationships that people have exist kind of outside of a doctor's office, and they predate even their visit to the doctor. So thinking about, especially in New York City, all of the community resources that we have available to us for people in terms of a harm reduction model, thinking about syringe exchanges that exist for our patients who might not be, ready, or might be on a medication but are still maybe co-using, and even thinking about co-occurring substance use. So if we're not even just talking about opioids, but also stimulants, thinking about how all these things kind of coexist. And I think we live in New York City, where it's actually the home of the United States' first supervised consumption site, where people can actually use opioids safely to prevent overdoses, which also falls into the category of kind of the first question, which is resources to prevent deaths from opioid use. And this was first done in Canada, and now it's done here. And so we have, very small landmass in Manhattan. We have so many resources that exist kind of also outside of our office. And so kind of when we ask this question and we may get an answer that's not necessarily, yes, I want to start buprenorphine, how can we equip ourselves by acknowledging and knowing those resources and communities that exist and bridging people to them? And so that can kind of help assuage this concern about the can of worms, because now you have tools in your pocket to say, okay, well, you can go to East Harlem and do this, and you can go to Washington Heights and do this, or you can go to the Lower East Side and do this. And they might not fit necessarily into the model of MAT, but can kind of coexist and can kind of support patients while they're exploring their medication options, but also even while they're on their medications.
I have a question, Joe, if I could. Actually, two of them. So we used to have little fishbowl things with condoms in our waiting room. Why don't we have naloxone kits for people, for family members and people in the community, since the prevalence is so high in some of the communities that we serve, where people can just sign something that they got one. They don't need formalized training in it. And we've had a number of circumstances where people have reported saving other people's lives. So it's not only the user that needs the kit, it's the people around them and people in these high prevalence communities. So that's one. And the second thing is, what's the deal with fentanyl testing at this point, test kits and stuff, and do we have them? Are they available? What's going on with that?
All right. So I mean, I can answer the first one. We also we have a very robust program of promoting Narcan kit distribution in the community. My understanding is because it's a medication that has to be prescribed. I don't think it's considered to be over the counter yet. We
have these little blue test kits that were given out by the city.
No, that's right.
We all but have them in the
to us.
fishbowl. I mean, we do have to hand them to someone, but they are, and we do give hundreds to the community. So yeah, an enormous number of them go to family members.
But there is a training component in that.
I think one thing that one of the upstate providers, they do is they have kind of navigators go out into the waiting room and proactively look for folks to sign up and give, even before providers are seeing people. And I think, and it could be, like non-opioid use disorder folks, people who just want to have a kit. I thought that was great. And I feel like that definitely will change some of the Narcan numbers that we have.
Well, one of the things that also turned out to be very, very effective has been the when we had upstate a care navigator who was just going through the list of people on the risk registry, and calling people up and saying, hi, I'm from the Institute, I see that, that you've been getting prescriptions for, opioids, and I'd like to know if we can send you a Narcan kit. And the uptake on that was just tremendous. It was very rare that people declined receiving that, and they were able to get a brief instruction, and then that was mailed to them, and that made a tremendous. And so talking about going into a waiting room, when we used to have crowded waiting rooms, that has good uptake as well, but for our patients who are at highest risk, just having someone doing outreach and having that kind of contact has been very, very effective. And I think that one of the suggestions of having more dedicated care navigators, especially for the New York City regions of clinics, so that we can start doing that kind of work, will make a very big difference. Because we have a certain number of people coming in and out of our offices every day, but we have a much larger residual pool of patients who are in our practice, but we maybe haven't seen for 3, 6, 9 months, who we can reach out to and get these kits to.
I was just going to mention to Dr. Gale's comment about proverbial can of worms and not feeling equipped to see patients. I think that's a feeling that as family med doctors, I think we feel often about various things at different points in our career. And I think to do something that makes you feel that way in a 15-minute visit is difficult, right? It is a little daunting. And I think, in the beginning, it's a little bit uncomfortable, and eventually it becomes a little bit more comfortable as you get more experience. I think we can do more in like curriculum training and like linkages to like online resources where people can kind of look through cases, but there's nothing like just doing the work and doing it and getting that experience. I feel like the way that I do it right now is I just wanted to point out, like, there's the addiction medicine fellows, there's the addiction medicine hotline, which I've used many times, both in precepting as well as in just, my own patient care. I think what I try not to do is like punch the case over to addiction fellows, and I try and just make myself a little uncomfortable and like kind of do that work and like then go to them for resources, and then kind of, which is what I do in women's health sometimes, what I do in like diabetes resources and all these other areas of medicine. So.
All right, well, it looks like we are past the 9 o'clock hour, and we all have day jobs.
Yeah, and thank you for the panel. This is incredible. We have to do this more often. There's such an incredible wealth of wisdom that comes from everybody. And everybody's perspectives are somewhat different. And it's just, this was fabulous. Thank you. Thank you so much for putting it together. And thanks for everybody that participated. Red?
I would just recommend we do this regularly. This is a great forum for a variety of clinical areas. We have something coming up next month as well. So I think, look, just keep tuned, because this is the start of an ongoing process. And I just want to, comment on using the data from our own practices is such a good opportunity to be able to not only look at what we want to do, but actually what we are doing. So proud of you guys. Thank you.
Yeah, well done, Joe. Thank you.
Thanks, everybody.
Thanks for having us.